So in this next piece, I'd like to show you, Mia showed some rather shocking numbers of the failure rate of development of novel therapeutics for Alzheimer's disease. And I'd like to just take you on a flyby through this just in a few minutes here. So here's my disclosure. I would point out that I had a very unique opportunity between 2009 2011 to actually join Big Pharma with a goal of developing novel Alzheimer's disease therapeutics. So they put $1 billion of funding in my hands and said, here, bring us a new successful therapeutic. And I would say it's not as easy as it looks. So here's the background to this. Subi told you about Dr. Alzheimer. This is one of the few pictures you'll ever see of him sort of smiling. He described not only the case of Auguste, but he also described the neuropathological hallmark signatures of senile neuritic plaques, which we now know to have an amyloid core, and neurofibrillary tangles, which we now know to include hyperphosphorylated tau that aggregates and destroys the cytoskeleton of neurons. And a large part of drug development over the ensuing years has been directed at removing the offending pathology. The assumption has been that if you could go in and you could remove the pathology, all would be well clinically. In the meantime, the cholinergic hypothesis in the early 1980s represented the first neurochemical palliative types of therapeutics. There are a number of approved medicines that enhance levels of acetylcholine with the effect of allowing better intention and engagement, so the frontal lobe's working a little bit better in some individuals with acetylcholinesterase inhibitors. And then in 2004, an NMDA uncompetitive receptor antagonist called memantine was approved. And then there has been radio silence on approval since 2004, despite a very deep investment in therapeutics. Mia showed this very interesting map, and everything to the left of center, so to speak, in red is an attempt at an amyloid-lowering therapy. Why amyloid? There's a number of lines of evidence that amyloid is a key neurotoxic protein that aggregates. It is the core of senile neuritic plaques, so it's intrinsic to the pathology of the disease. There are genetic forms of the disease where autosomal dominant mutations involving amyloid invariably cause the disease. There's also a protective mutation next to one of the cleavage enzymes of the base enzyme, where people who have the mutation do not get the disease and do not get cognitive impairment. So there's a pretty strong smoking gun around amyloid, yet we have expended enormous amounts of effort. So we have, with deep science, learned the sequence of amyloid processing through its monomers into its oligomeric species, into beta-crystalline sheets, and into plaques. There's been a remarkable effort to develop all matters of interventions along this pathway. The approach that has been taken has been to start in the mild to moderate stage of the disease when the pathology has been advanced. You've heard this morning, the pathology builds up over 20 years before people get the disease. So there's quite a cascade of events that have occurred by the time we have initiated these trials. So not only has there been a focus on prevention with lifestyle interventions, but there's also been a sense that if you're going to intervene successfully on a target like amyloid, you may have to intervene several decades before. The immunotherapies represent one such avenue, particularly the idea that you might be able to actively vaccinate against amyloid in individuals that are at risk. And perhaps the genetic forms of the disease with autosomal dominant forms would be the best target population as our proof of principle for this. So that's the map of where we've been. This is the money slide, as it were. There's probably about $10 billion worth of effort on this slide, and unfortunately, the primary analyses on each of these research programs have been negative or terminated. There have been, if you squint your eyes and you look at sub-analyses, some of which have been pre-specified, there are some signals that come out of this that maybe the genotype of apolipoprotein E4 has a more robust effect to amyloid lowering, but it was not associated with clinical benefit. Maybe milder patients are benefiting more than moderate patients, perhaps supporting the idea of earlier intervention. Although it's not entirely consistent, if you look at intravenous gamma globulin, which had a clinical trial, moderate patients benefited more than mild in that one. I think what is very striking, if you take a higher level look at this, is the idea that actually, if you look at brains where amyloid has been removed, or you look at where amyloid lowering therapy has been given, amyloid has been removed from the brains, but patients have not actually benefited. So we're in a quandary over the fact that we can remove the offending target pathology, particularly one of the primary pathologies, without apparent clinical benefit. And the field is in currently a state of debate saying, we're almost there, we need to stay the course and invest further, against those that are saying, this horse has left the barn, it's time to move on. And that's a very open argument right at the moment. The field has turned its attention to the second signature pathology, tau pathology, and tau pathologies actually are more invariably associated with cognitive disorders. It's interesting that the amyloidopathy that builds in the brain has a very poor correlation to cognitive impairment. Tau pathology corresponds a little bit better. If amyloid and tau, which are being actively pursued, are not successful, this is what the map looks like. And I think a few speakers this morning have indicated to us the targeting of this disease is more complex, and we have oversimplified our models. We said, wouldn't it be nice if we made an amyloid-lowering therapy or a tau-lowering therapy, we targeted the pathology, and all would be well? I think we've come to understand that the cascade's going to be far more complex. So I think there is not likely to be a home run for sporadic disease anytime soon, allowing us to put in context the rest of our discussions over the course of this day. It's not to be, in Subi's words, it's not to be a pessimist, but it is to say, if you're a government and you have $100 and you have to spend your money, what are you going to spend it on? Are you going to invest along this line? You're going to expend it in prevention? You're going to expend it in risk factor modification? This is part of the discussion we'd like to have with you today to get your viewpoint. It all affects you in some way or another, but we wanted to just lay out the case for you. So the summary of where we've come to in treatment is no new therapies in 12 years. There's still enormous unmet need in treating symptoms, both cognitive and behavioral. We have the tantalizing prospect of prevention of disease and sort of what that looks like. We need treatments that will sustain benefits over the course of the disease. There's been a deep investment in amyloid-lowering treatments, mostly negative. We don't have a good, well-formed plan B. So far as I can see, if there's a plan B, no one's whispered it in my ears yet. There's a unique opportunity for academic networks to innovate and lead. So I think the CCNA is very well positioned to deliver value in that regard. And I think that there are a few other more technical aspects of this. So